today I'll be talking about proteolysis targeting chimeras, also known as PROTACs, as treatment for metastatic mCRPC. So the objectives for today, I'm going to start by talking about the basic principles and mechanism for action for PROTACs, move on to talk about the potential benefits and challenges of using PROTACs for therapy, then put that in frames of a recent clinical trial that's currently still going on for mCRPC. Traditionally, drugs are developed based on these two mechanisms. And when I talk about drugs here, I meant small molecule drugs. So they, one, behave like a competitive inhibitor, where the small molecule outcompetes the native substrate, thereby inhibiting the enzyme from carrying out its native function. Second, you have the non-competitive inhibitors, where the small molecule binds to a remote allosteric site, inducing a conformational change or some sort of steric bulk into the substrate binding site, making the substrate binding site inhospitable for the substrate, and thereby, again, inhibiting the enzyme function. Putting this in the frame of androgen receptors, AR, testosterone is a native substrate for androgen receptor. One of the first androgen receptor, AR, antagonists that's developed was cyproterone acetate. As you guys can see, it shares the same four ring core cholesterol structure as testosterone. Most recently, though, the enzalutamide that has been developed as an anti-androgen therapy behaves just like a competitive inhibitor as well, despite not sharing the same core structure. In addition to the competitive inhibition, it actually also has decreasing the androgen receptor translocation to the nucleus, as well as inhibiting DNA binding upon translocation of DNA, upon translocation into the nucleus. So that means that enzalutamide not only has competitive inhibition activity, on top of that, it also acts via a non-competitive inhibitory function to stop the AR from being translocated into the nucleus, as well as stopping DNA binding on when the translocation occurs. PROTACs behave on a completely different manner. It co-opts a naturally occurring protein recycling mechanism that's in cells to eliminate target protein. Right this second, everyone's cells are making different proteins to carry out different functions. And as these proteins are synthesized and sent to different locations, they get degraded, truncated, oxidized. Things could happen to these proteins that causes them to lose its native function. And so one way that cells have developed to recycle the inactive or trash proteins back to its amino acid stock is through proteasomal degradation. And so a PROTAC is based on this design where you, by putting a protein of interest ligand in and linking it to a ligand that is part of the proteasomal degradation machinery, E3, you can artificially bring the protein of interest to proximity to the E3 ligase machinery, thereby degrading the protein of interest. One thing that's worth noting here is that PROTAC behaves like a catalyst, meaning that once the protein of interest has been marked for degradation, the same small molecule can then go on to bind to a different protein of interest, and so on and so forth, until the small molecule has been modified, degraded, or trashed somehow inside the cell. And so PROTAC has the potential of knocking down proteins inside cells down to sub 90% or more range. Before I move on, I want to briefly talk about the pharmacodynamics and pharmacokinetics for PROTACs. Because PROTACs by nature have two ligands, one for the protein of interest and one for the machinery that's responsible for recruiting proteasomal degradation, we need to consider two different types of ligands and optimizing two different types of ligands for it to behave at the highest potency, whereas the traditional drug shown on the right only has one ligand, and so just one thing to optimize. And because of the two ligand design, we also have to consider there's doubling the chance of off-target binding, whereas the traditional drug, there's just one molecule, one off-target possibility. And number three, the nature of having two ligands linked by a linker means that there are three things that you could optimize. And actually, research have shown that by modifying the linker between the two ligands, they can induce, what people have shown to be able to induce biological differentiation just by changing the linker length, size, and rigidity. A little bit on the pharmacokinetics. Traditionally, drugs live within what medicinal chemists would call the rule of 5 space. Briefly, the rule of 5 is an empirical observation that a medicinal chemist had described, where it follows this, where small molecules are less than 500 kilodalton, they have less than 5 ionic donors, so on and so forth. But because PROTACs by nature has two ligands, its size is doubled than the traditional small molecule. And so it behaves unlike the traditional small molecules. And so it is harder to predict its bioavailability as well as solubility when you take it orally. Lastly, PROTAC, because its function goes through degradation, it is harder to predict its adverse effects, given that you're no longer inhibiting a protein's function, but rather you're involving a whole slew of cellular machinery to target this protein. A little bit of history on PROTACs. It was first developed by Craig Crews here at Yale and Kathleen Sakamoto back in the early 2000s. In their first paper shown above, they used a peptide chain as the E3 ligand. And that's why it was never really quite picked up by biotech company because of its bioavailability as well as shelf stability issues. So it was not until 2015, and this Nature Chemical Biology paper, where Craig Crews described the first two true small molecule PROTACs that are capable of degrading proteins down to more than 90% level at sub-nanomolar ranges. The E3 ligand that they used was a small molecule that recruits VHL. Right around the same time, Honda Group from Tokyo also described or found the primary target for thalidomide, which turned out to be another E3 complex protein called cereblon. And so the occurrence of the first development of PROTAC small molecule, as well as the identification of another potential E3 ligand, kind of causes bursts of biotech development. And one of the companies that was started by Craig Crews, called Arvinas, is here in town in New Haven. And this is one of their first drugs called bavdegalutamide, also known as ARV-110. So you guys can see on the right-hand side, in pink, the chemical structure here resembles the thalidomide from the slide before, and the far left side circled in cyan, the ligand for androgen receptor was found via chemical screening. This drug is currently in phase 2 trial, and the phase 3 trial is due to initiate later half of this year. So for the next few slides, I'm going to talk about the development of this drug, as well as the data that they have shared through investor press releases, as well as the poster sessions that have gone to in different cancer conferences. In the preclinical phase, what they found with ARV-110 was that it was capable of degrading androgen receptor selectively in VCAP cell line with incubation of 8 hours at 10 nanomolar. And they were able to achieve 85% degradation maximum with this drug. On top of that, when used with a murine xenograft tumor model, where the tumor is a enzalutamide resistant VCAP cell tumor, the mice that were fed ARV-110 at 10 milligram per kilogram POQD had tumor inhibitory effect up to 80% when compared to the vehicle and enzalutamide fed mice. And so with these data, they pushed on and carried out the first phase 1 trial. And the patients were men with mCRPC who received more than 2 prior therapies, including abiraterone and or enzalutamide, amongst other therapies. What they found through the phase 1 trial was that people who received more ARV-110 have had reports higher activity, meaning tumor inhibitory or PSA reduction activity, and that this drug has enhanced activity towards a specific subset of patients. These patients carry the ART878X/H875Y positive tumor. And what they report was 40% of a patient, 5 of a patient, had PSA reduction rate of more than 50%. Additionally, they found that 420 milligram QD was the optimal dosage based on safety, pharmacokinetics, as well as efficacy. And so they carry on to do their second phase trial. Again, the eligibility criteria for the patient is patient with mCRPC, as well as disease progression since most recent therapy, and that's defined as more than 2 risings of PSA values with more than 2 nanograms per milliliter. They, again, subsetted the patients into different biomarker groups, and they fed these patients with 420 milligram QD of ARV-110, monitored and allowed them for dose reduction as well as interruption based on adverse events. The primary endpoints are PSA response rate, RECIST response rate, and PFS and rPFS. At this moment, they have not reported any data from the PFS and rPFS. And so for the following few slides, I'm just going to be talking about PSA response rate and RECIST response rate. Here are the baseline characteristics of the patient. Median age is 74, 70 for the phase 1. As you guys can see, the phase 2 trial had almost double the number of patients, with 31% of the patients having visceral disease, and median number for prior lines of therapy used was 4, with 1 being on the low end and 11 being on the high end. And here are the hormones that were used as first-line therapy. Adverse events observed using ARV-110 was seen in more than 10% of the patients, and in actuality, it was 83%. That said, there were no grade 4 or grade 5 adverse events, and on top of that, people tolerated the drug well with additional symptomatic treatments or reductions in dosages. So with the phase 2 trial, they saw that 46% of the patient with this ART-A78X/H875Y genotype had PSA reduction of more than 50%. Again, this may not seem like a very encouraging number, but just to remind you, these patients have failed multiple lines of treatment up to this point, and so this is actually quite encouraging, and I think that's why they push on this number pretty hard when they release their data. Additionally, 2 of the 7 patients with this genotype also had confirmed RECIST partial response, with 3 having stable disease and 2 had disease progression. As far as the timeline, 43% of the patients were still on ARV-110 earlier this June when they released this data. They did not mention why the 57% other group stopped taking ARV-110. And so that will be something interesting to see when they finally release this data set. Lastly, as I've mentioned before, this drug works really well for the T878X/H875Y genotype. However, this drug doesn't work quite as well for the wild type, where, as you guys can see, the PSA 50 is only 11%. And when there are co-occurring mutations, such as L702H/ARV7, just briefly, the ARV7 mutation is when the ligand binding domain has been mutated out and the androgen receptor is constitutively active. Within this population, the PSA 50 rate was only observed in 4% of the patients. And lastly, with patients who have only received 1 line of novel hormonal treatment before initiating on the ARV-110, the PSA 50 was 22%. But as you guys can see, most of these people who behave or had a positive response to this drug also harbors the more sensitive genotype to this drug. And so that said, Arvinas was quick to develop another drug that targets or that has a wider genotypic coverage. It's called ARV-766. Still the same E3 ligand, but they modified the androgen receptor ligand to have it cover more genotypes. And this past July, they released data on this drug saying that the PSA 50 was observed at 42% of the patients with various type of AR mutants. But if you look closer, the end of this cohort was only less than 20 people. And so I'm not sure if they truly have the statistical power to kind of make the same claim here. So again, it's gotta wait till their true data set comes out to be able to evaluate its efficacy. Last slide. I just want to illustrate that there are many PROTAC drugs coming on the horizon, with quite a few going through clinical trials and few that's being developed right now. The prostate cancer drugs, 2 from Arvinas, 1 from Bristol Myers Squibb, and 1 from Proteovant. on top of that, there are other PROTAC drugs for different malignancies. And so as we proceed on our training, be on the lookout for these drugs because they have different mechanism of actions, and so they could behave synergistically with other pre-existing small molecules. So with that said, thank you guys for an awesome month. I've had a lot of fun working with you guys in in the OR and in clinic. This is one of the small molecules that I synthesized as part of my doctoral training. As you guys can see, it's gold as a solid, but in liquid form it's purple. This is what I meant by color changing dyes. Anyways, I'll take question now if anyone has any questions.
Super interesting. It's kind of the first time I'm hearing about the PROTACs, but do they generally target the kind of receptor and the ligand receptor? And so is there continued risk of competition, or if there's a mutation that is no longer receiving the ligand, that the PROTAC would be ineffective as well?
Yeah, so that's a good point. With this design, they don't have the crystal structure of the small molecule inside androgen receptor, so they don't really truly know where it binds. But with cross-linking study and proteomics, they're able to deduce that this ligand actually binds at a different site that is not at the ligand binding site. And so that's why they postulated that's why this drug has a better coverage amongst different genotype mutations. A lot of these mutations are kind of driven by treatment of anti-androgens therapy. I have a slide for you. So here are some of the common AR mutations that's seen. And as these mutations happen with different drugs, they actually change its activity profile. And so one thing that PROTAC protects against is this, that you will not have a PROTAC that, at least for a brief period before we can catch it, goes from an antagonist to an agonist, because it is still degrading as long as it binds to the androgen receptor. It is still carrying out its native function to destroy your androgen receptor. Does that make sense? Yeah. Any other questions? Yes, sir.
So I find it very interesting that it was so specific in terms of the mutation, kind of looking at a broader scope. Is anyone looking into kind of trying to predict which mutations are going to happen based on the sequencing of what medications were given?
There is a science translational research paper that looked at there's an evolutionary biology term, like there are regions of androgen receptor sequence that are more prone to mutation. And so in that vein, yeah, people have looked at it, but I think just because how cancer cells behave and how we are essentially selecting for the mutant androgen receptors, we will see these cancer cells do whatever they can to escape this mechanism. And so one thing that I guess many people probably think about is, well, what if we start by using this drug in conjunction with other anti-androgen therapy? So change the sequence of treatment to see whether or not if we get better efficacy. And actually, Arenas have a current phase 1 trial with ARV-110 as a first-line agent, in addition to arbitrate. That's
As part of the side effect profiles, you weren't seeing the typical anti-androgen or effects, so like libido, erectile dysfunction, breast tenderness, gynecomastia.
Yeah,
Is it just we're just past that for these patients?
I think so. I don't really know, to be honest with you. It could also be just quite short amount of time. This is interim data release, so I'm not, but interesting to see when they finally release the data later this year.
Probably more important if they're thinking about utilizing it up front.
Early line, yeah. Anything else? Anyone?
Thanks. Great job.
Thank you.
I'm Max Rabil, and today I'll be speaking about the hidden bargain, financial toxicity, and decisional regret in urology. So I hope to frame the impact of financial toxicity and decisional regret in urology through real-world case examples, explore the urologist's role in combating these challenges for our patients, and then discuss procedure-specific examples and potential solutions. And so to cut is to cure, right? That's how my surgery clerkship orientation opened up. And while the power of the scalpel is very fascinating and awe-inspiring, we do have to be cognizant of the damage that it can cause. And now when that damage comes in the form of complication, it is very well recognized. But when it comes in other forms, such as injury to a patient's financial status or overall mental well-being, it's a little bit more nebulous. And so the problem at hand that I hope to explore here a little bit is, when we're starting with financial toxicity, it's a growing interest in medicine, throughout fields of medicine, that tries to characterize what sacrifices patients are making. So it looks at, of course, the overall cost of their procedure, but also what are they sacrificing in order to maintain their care and meet the needs of that cost. And so, as I've said, it's say from the literature, about 2018 or so was when it seemed to take off. And since then, there's been a validated cost questionnaire, which I'll show on the next slide. But what I think is important to understand is that this is not a problem that's isolated to the economically disadvantaged, as bankruptcies due to medical bills occur in 75% of those cases occur in patients that have full insurance. And moreover, there's a strong literature base showing a correlation between financial toxicity and worse overall health outcomes. And decisional regret is a little bit of an older term and concept, but largely is kind of defined by each study that looks at it. But as the name implies, it looks at patients regretting their procedures for whatever reason, or their medical management for whatever reason, be it that their outcome was not what they expected, or any number of things. And so with all these things going on, the question is, are patients avoiding care? And in one review of oncology patients across specialties, they did find exactly that patients would avoid filling prescriptions, they would skip visits, all in the name of trying to save money. But I'll get into, there's a little bit of a caveat there for urology. And so with that, then, in the same vein, financial toxicity and decisional regret is largely studied in uro-oncology, although, as I'll get into in a little bit, it is starting to creep into other fields as well. But the most robust survey or review that I found surveyed uro-oncologists who did report that they really feel unprepared to have these discussions of costs with patients, and that they're worried that if they bring it up with them, that the patients may perceive that as a shift in focus from their best outcome to really assigning a dollar value to, years of life or quality of life. And so they're worried that that may erode the trust with their urologist. And so the duty that urologists have to fight this, a lot of it with insurance companies is out of our hands, but there is still a lot that we can do. And I think ultimately the primary goal that we should have, and the primary duty of us, is to educate our patients and make them aware of what is to come, and so they don't get blindsided. And so here again, this is the cost survey. It's a validated instrument designed to assess financial toxicity, with 11 questions and scored 0 to 44, with a score of 0 representing the highest financial toxicity. So the first study is a study of financial toxicity in metastatic prostate cancer. And so this group out of Mayo Clinic were driven by the fact that There's now over a dozen treatment options for metastatic prostate cancer, many of them being multi-component regimen that, despite being on the market for many years, continue to go up in price, and also in spite of the release of generics. And so they wish to see how prevalent financial toxicity was and get an insight into how that financial toxicity actually impacted their patients' day-to-day life by looking at their coping strategies. And so what they found from a patient factor standpoint is that 28% of their patients expressed high financial toxicity, but 54% did, and sorry, I didn't define what they said was high financial toxicity. So a score of 24 or below was high financial toxicity, and then 24 or above 24 was considered low financial toxicity. And so 28% expressed high financial toxicity, but 54% expressed some sort of financial struggle. And those that were younger and lower income were more likely to be in the high financial toxicity group, as well as those receiving infusion therapies such as chemotherapy or radium. And then also, interestingly, those who had shorter treatment durations had worse ratings of toxicity, likely due to the fact that they have less time to sort of grapple with everything that they're going through. And then some protective factors that they found that had a significant impact were being married and then enrolling in financial assistance programs through the hospital. And so that's certainly one thing that we can consider. I guess we can't really recommend patients getting married, but it can certainly help them enroll in financial assistance programs. But also they asked their patients what did they think about the surgeons discussing the cost of their care. And interestingly, 60% in the high financial toxicity group said that it should be considered in some way versus 40% in the low financial toxicity group. But 30% in that high financial toxicity group said absolutely not. I don't want cost discussed in any way, which kind of raises the point that this is not a monolithic group. It's really a personal decision. Some may be more sensitive and feel that sensitive to the fact that it may feel like you're assigning a dollar value to their health. So it might be an impetus to, before we start these conversations, ask permission, see what they think before really diving into it and potentially ruining the rapport. And then looking at the coping strategies that their patients went through, those in the high financial toxicity group were more likely to decrease spending on basic goods and leisure. They'd pull from their savings, delay filling prescriptions, and borrow money. But in contrast to that initial survey or initial review that I mentioned, these patients did not skip visits or refuse tests, which I think is unique and interesting that we were fortunate to have such a diligent and fervent group of patients that are willing to, find ways to be compliant with their care. And so that's a, unique opportunity or a unique aspect of urology, I think, at least based on this study. But moreover, it's important to take away from this that just asking a patient, can you afford treatment, is not quite going far enough, given that there's a lot of resilience in finding ways to sacrifice many other aspects of their life in order to maintain compliance. So we do have to go a little bit further than just asking, can you afford this? And then the next study that was highlighted by the AUA about a year ago in a little announcement looked at decisional regret after diagnosis of a benign pathology from a small renal mass. And so the crux of the issue here is that with more and more imaging and better imaging, small renal masses, namely 3 to 4 centimeters and below, are being found more and more often, but it's still very difficult to discern benign versus malignant, with as many as 10 to 30% of patients that undergo partial nephrectomy for these small renal masses coming back with benign pathology. And while that sounds like good news, these patients that were surveyed, 49% of them who had pathology come back as benign after all this workup expressed significant regret, and only 42% thought that their choice of treatment was wise. And this is even more stark when you compare it to the decisional regret rating of radical prostatectomy, which of course I think we can agree is a more morbid procedure with common incontinence and impotence, which only rated 30% severe decisional regret. And then the study also provided some qualitative feedback, which I thought was very enlightening So we can see into the patient's mind, kind of understand what they're thinking. And so I highlighted a few things here. They thought that their thoughts from the get-go that perhaps this mass was benign. Those thoughts were valid, but not appreciated by their urologist, or that operating on a mass that could turn out to be benign is archaic and inhumane, or that they're just as vulnerable as a person that came back with malignant pathology. And while these responses likely do skew towards the negative end of the spectrum, I think it's still very sobering to think that there's even a small subset of patients that we treat that may feel this way, especially in reaction to what we would normally say is good news, that your pathology is benign. And so in addition, this same study did administer the cost survey to assess financial toxicity, as these patients felt that they're paying all this money for something that ultimately didn't benefit them in their mind, and that is an unnecessary cost. And they found that the average cost score for these patients was 27, so just a smidge higher than what was defined as high financial toxicity in that previous study, although there is no set threshold of what's high or low. It's always set by individual studies. But nonetheless, these patients were feeling that they were paying a lot of money for something that was unnecessary. And so this next study out of the University of Virginia split their small renal mass cohort into receiving either partial nephrectomy or percutaneous microwave ablation, with the thought being that by employing the microwave ablation, he could reduce cost, and then theoretically it's cheaper, and if it does come back as benign, they'll have less regret and feel less financial strain. And so what they found was that the microwave ablation was about a third as expensive, so that's great, but the recurrence rate was 5 times higher, so that certainly comes at that price. And their conclusion was that by holding a localized renal mass board similar to a tumor board and discussing which patients are best candidates for which treatment, and then using that information to educate their patients and allow them to make shared decision making, that was their positive solution to this. And so finding the right balance for the patient that perhaps wants to save money and is willing to have the sort of mental stress perhaps of maybe my cancer is more likely to come back, versus finding the patient that really is losing sleep over even the slightest chance of their cancer coming back can help inform which treatment option to pursue. And moreover, other options to help mitigate these problems in small renal masses include imaging and renal mass biopsy. And so again, as I mentioned before, CT and MRI are becoming more and more detailed, but still it's not perfectly reliable to just go off of the imaging to inform a patient. And the latest advances in radiogenomics and AI hope to capitalize on that increased detail by detecting patterns in the imaging and then better predict whose imaging represents malignant versus benign pathology. And it's very enticing, but again, is unreliable. The next option is radiographic surveillance, which in the right patient, appropriately selected patients, does not compromise survival. So that's another option that can help hopefully mitigate these problems. And then finally, the addition of renal mass biopsy, especially with development of in-office techniques and advances there, can perhaps be the next step to help these patients avoid procedures that they would regret and go through financial stress for. And then, as I mentioned, again, the bulk of the literature does seem to be in uro-oncology, but it is starting to come up in other subspecialties as well. And so in hypospadias repair, 11% of parents express significant regret in the decision that they made. And that decisional regret is associated with poor penile appearance, cosmetic appearance, feeling that the surgeon was not involved in helping the parents make the decision, and then just overall lack of clarity during the decision-making process, which is kind of a theme, the lack of clarity and lack of knowledge. In feminization surgery in congenital adrenal hyperplasia, it's an example of a job very well done. 68% of parents express no regret at all, but the third that do, again, cite lack of clarity in surgical decision-making. In stone management disease, 1 in 5 patients will meet criteria for high financial toxicity, and about 40% of those patients feel that their surgeon should have discussed or taken into account their financial status when recommending decisions. And then finally, male stress urinary incontinence is kind of a counterpoint to how I opened with to cut is to cure, the cautionary tale there, because what we actually see is that 34% of patients that undergo conservative management of their incontinence will have significant regret versus only 8% who undergo operations for slings and artificial sphincters. And so this is an example, perhaps surgery is underutilized and patients may benefit from knowing, hey, these slings and sphincter procedures are very well appreciated and regretted at low levels. Is that something that you would want to consider? And having that other, a patient's perspective, the perspective of a patient who's already gone through it may help them be able to better explore their own thoughts on the process. And so overall, some general improvements. I think real key to all of this is having these discussions with patients. When they feel blindsided by surprises in their care, more expensive care, or just really coming back, again, surprises, being blindsided, that seems to be what is the root of their regret. And also by not being prepared for the financial struggles that may come, they are worse off. And so again, saying some patients might feel this way in the discussion, allowing them to understand how other people feel, and asking, do you want to discuss the cost of your care, or ways that we can maintain shared decision making while also getting the appropriate approval from the patient to discuss it, as well as giving them a place to start and making sure that they're at a level where they can really make an informed decision. And then finally, decision-making guides are a great way to help decrease decisional regret. We had a great talk a few months ago from Dr. Janet Kukrasia, who had a clinical trial of a decision-making guide for urinary diversions that seems to be making a real impact for her patients. So all in all, our patients harbor under-recognized compromises and regret after receiving urologic care, but promisingly, urologists are paying more and more attention to this, and there's already good examples of jobs very well done in some fields and procedures. And the key to kind of closing this gap is by starting conversations with our patients, making sure they understand what is potentially down the road for them, and so that they can properly plan their finances or properly expect that maybe I'll go through all this and it will be benign. And by knowing that, they will hopefully have less regret and less financial toxicity. And of course, shared decision making should be the cornerstone of these conversations. So with that, I want to thank you all for having me this past month and for listening to me, and I'm happy to take any questions. Thank you.
I wanted to ask, so in that study of benign renal masses, there was the decisional regret that you had mentioned. But I wondered, have they studied it in patients who had a diagnosis of a malignant mass? Do they regret undergoing that evaluation? And furthermore, for the patients who had benign renal masses, did they ask them if they had a diagnosis that it was actually malignant? Would their decision about decisional regret have different?
Right, yeah, so I have not seen the same sort of study in patients that have actually had malignancy, but I've thought at the same point, is like, right, these patients objectively do have a better prognosis by having benign pathology, and so that it's very emotive. It's hard to, in the nature of decisional regret, right? It's very emotional, and so of course the highs and lows of going through everything just to then be surprised by it being benign pathology can be a real emotional roller coaster. So I think that's kind of where this stems from. But yeah, and what was the second part of your question?
If they had followed up with the patient
Right.
who had benign renal masses and asked, had your diagnosis been that the mass was malignant, would you still have had decisional regret?
Right. No, they did not follow up on that, although I know in this the second qualitative feedback excerpt, this patient said that they feel that they would be just as vulnerable as if their pathology had come back as malignant. So I do think it's kind of a personal, person-to-person variant response. But I do think that that's sort of an important question to ask, because it is obviously skewed in one direction here.
wonder if it's lower for the prostatectomy folks, because you're not gonna do a prostatectomy without a cancer diagnosis in the
Right.
end, and there's no question, even though the benefit of prostate cancer treatment may not be as great
Right.
as renal mass. Was there any indication of what kind of drove the patients to seek the care, if that altered it? You know, I'm wondering, you know, you see these people undergo facial plastic surgery and nobody's telling them, like, you need to fix your nose, here's a referral to a plastic surgeon. It's patient driven, and a lot of cancer diagnosis and management is done through screening, so patients are feeling fine, and then someone tells them this lab came up funny, you need to go and investigate it. So it's not something that's bothering them, and then we're imposing diagnostics and treatment on them, and it's really disruptive to their well-being.
Right.
Whereas, you know, and within the kidney stone world, we have incidental kidney stones that get a lot of referrals for, like, a 5 millimeter lower gallstone that was found during appendicitis, and they're none the wiser to it. And there's the people who are in extremis from pain.
Right.
And is there decisional regret in pursuing treatment if they're actually fixing something problematic or symptomatic, and if the patient is driving the seeking out the care as opposed to being referred for something that's not bothering?
Right. Yeah. None of these studies stratified on that, but I do absolutely think that that's an important question, because I know just from some of the reviews in medicine as a whole, there was one line that sticks out to me about plastic surgery being very low, having very low regret. So I do think that is kind of, that all of this is kind of confounded by patients' intentions. If they're coming in seeking treatment, they're probably more likely to not regret it as much, right? Because they initiated it. So I do think that that's an important thing to also consider in this, right? Exactly, that some of these patients are kind of having it forced upon them in one way or the other, you know, not necessarily that we're pressuring them to it, but it's just the situation, they need this treatment. So yeah, I think that's a good point.
And then with plastic surgery, elective cosmetic plastic surgery, the unique aspect being that you're paying out-of-pocket cash, and so I think there is an upfront discussion of this is how much it's going to cost you. Or like if you're having orthodontic work done, it's very clear, like it's going to cost you this much for the course, and there's no. Whereas I have no idea
Exactly
what anything's going to cost. I think Dr. Kenny.
Yeah, I see some things in the chat.
Max, great talk. I just wanted to remind everyone just of the point that renal mass biopsy is super, super helpful, but also not always perfect. And the negative predictive value of renal mass biopsy is not super strong. And there was a review, about 8 years ago, that looked at renal mass biopsy, and in that series, almost 40% of people who had a negative biopsy who then went on to surgery actually were found to have cancer. I mean, and it was retrospective, so there may have been other reasons that someone with a negative biopsy went on to have cancer, but it does, kind of, I think, raise some caution that not all of that histology change, between biopsy and is going to could be fixed by doing a biopsy, right? So even if you do a biopsy, it may still be wrong. And there is a role for sestamibi, but it's still really uncertain what that role is. But the two combined of biopsy and sestamibi may be helpful. And there are some, there was at least one paper looking at the potential cost savings by using renal mass biopsy and sestamibi.
Right. Yeah, no, absolutely. I think it's clear that there's no perfect solution to it, but perhaps the best way is by preparing these patients, because again, these surveyed patients with decisional regret were citing that they had no idea or they felt that they had no idea that they could go through all this and it would end up being benign. And so again, the cheapest and easiest way really could be, and even most effective arguably, would be just discussing with them and setting expectations so that they don't get surprised by these bumps in the road.
Last question.
Yeah.
Hi. So I know a lot of this comes down to education.
Right.
And so are there shared decision-making tools for some of these either benign or malignant conditions that help guide, that have either been studied that could help guide people to have that conversation?
Yeah, I certainly know. I don't know, to be honest, if there are some that have been established, but I do know like Dr. Kukreja is developing a decision guide. So I know for a fact that it is something that's of interest in is being developed. As to if there's things that are out there already, I'm not sure. I haven't seen that.
I mean, and the data are changing all the time,
Right.
you know, and I think another part of this literature is interested in trade-offs. Like,
Right.
what are patients willing to trade off? And that's like really different for each patient, and it's really hard to have that conversation with each patient in a
Right.
kind of non-standardized way, which I think is where some of those shared decision-making tools can be helpful, you know, and I'm doing all benign quality of life, so I'm like, look, this is the worst possible outcome.
Right.
The worst possible outcome is you do your prolapse surgery, don't do a sling, you have terrible incontinence, and you have repeat surgery in a year for that.
Mhm.
And you might be miserable in the meantime. Like, how does that sound? You know, or the best case scenario is you avoid, you know, you know, some patients are better at navigating that than
Right.
others, and some patients have more of an appetite for, I just want it gone no matter what, because I want it off. I just do the sling. Just
Right.
do it. I might not need it, just do it. You're in there, do it. Other people are like, really like, ooh, like, I don't want those complications.
Mhm.
So it's a lot. It's a lot of work.
It definitely is,
And I'm
right.
not sure how much of it they actually retain, knowing that like a single person sitting in front of you, there's data that they retain like 30% of what
Right.
you say.
Right.
So, you know, the whole informed consent thing comes down, but
Yeah.
it's difficult.
No, it definitely is. And I think, again, like it would be naive to think that, oh, we can sit down with every conversation or with every patient and have an extensive conversation on every aspect of where their care may change and what surprises may come down the road. So I do think exactly that like having tools that perhaps they can review before their visit and, you know, fill out surveys to assess, you know, these are the things that they would be willing to give up would be a great start to jump off of. And ultimately, I think this is more an aspirational goal than one that can really get to 100%. But I think moving in that direction is for the best. Yeah. But all right. Thank you.
Good job.